Hello and welcome everyone. Today's presentation is on management of swallowing disorders in ICU patients. So swallowing has three phases: a oral phase, a pharyngeal phase, and a esophageal phase. The problem mainly lies in the ICU during the pharyngeal and the oral phase, where due to the weak nerves and muscle weakness, the patient is unable to send the food particles into the esophagus. Dysphagia is defined as a swallowing disorder that often occurs in ICU patients resulting from multiple causes like trauma, neuromyopathy, cognitive impairments. The risk factors for this are neurological disorders, emergency admission, severe illness, old age, high Apache, and prolonged tracheal intubation. Medical conditions associated with increased dysphagia risk are heart failure, sepsis, hypercholesterolemia, extended surgery time, and repeated intubations. Significant percentage of patients exhibit swallowing issues post-extubation. 18% fail initial water swallow screening, 41% develop post-extubation dysphagia, and 36% silently aspirate. Nearly all patients with tracheostomy face swallowing difficulties. The consequences of dysphagia are severe and long lasting, including increased risk of aspiration, pneumonia, malnutrition, prolonged ICU and hospital stay, and elevated mortality rates. Dysphagia effects can persist for up to 5 years, impacting up to one third of the patients. Despite its significance, it is often unrecognized and is often unmanaged in the ICUs with inconsistent screening and limited guidelines. Only a small percentage of ICUs globally adhere to specific dysphagia protocols, with 30% assessment for dysphagia after 48 hours and 41% after tracheostomy and 67% after extubation. Effective dysphagia management in the ICU demands a multidisciplinary team, including critical care intensivists, neurologists, gastroenterologists, physicians, dysphagia specialists, nurses, nurse practitioners, dietitians, and physiotherapists. Depending on the local practice, dysphagia specialists may be speech language pathologists, specialized ENT people, organized or occupational therapists, and physiotherapists. Establishing a specialized dysphagia team ensures consistent evaluation and management by experts with a comprehensive understanding of the swallowing disorder. Impaired airway safety and secretion management are better predictors of extubation failure in ICU stroke patients than traditional respiratory weaning criteria or the level of consciousness. Emerging data support the use of bedside screening tools that determine extubation failure in severe stroke, stroke-related early tracheostomy score to identify patients who are at extubation failure and tracheostomy risk. Early identification and intervention are crucial to minimize complication, as most patients lose swallowing coordination, sensation, and muscle mass by the time they are extubated or tracheostomized. Emerging evidence suggests pharyngeal electrical stimulation may improve swallowing and health economic outcomes in intubated patients. Other neurostimulatory techniques report preemptive swallowing stimulation, neuromuscular electrical stimulation through evidence-based practice remain limited. So now that we know that this is a major problem in the ICU and it is not something which is actively done in most of the ICUs, we must first need to understand how do we screen a patient who has dysphagia. So first is the extubated patients. We have two patient category: the extubated patient or the tracheostomized patient. The data regarding pre-extubation patients is limited and we don't know exactly how to manage that part, but that is very insignificant. The most important patients are the extubated ones and those who are on tracheostomy. So first we will discuss how to assess the dysphagia in extubated patient. The most common protocol that is followed is the Yells swallow protocol. There are some exclusion criteria, that is, the Yells swallow protocol should be deferred due to no concern of aspiration risk. As long as the patient has no concern for aspiration risk, then only we should go ahead with the test. If the answer is yes to any of the following, then the patient is probably having some problem. The patient is unable to remain alert for testing, eating a modified diet due to pre-existing dysphagia, existing enteral tube via the stomach and the nose, head end restriction of less than 30%, tracheostomy tube placement is there, or there is an NPO order from the physician. If the patient's clinical status changes resulting in a new risk of aspiration, the protocol must be re-administered before oral alimentation or medications are ordered. So if the patient is deemed as an aspiration risk and all exclusion criteria in step 1 are checked no, then you proceed with the particular test. The first is you do a brief cognitive screen where you look at the orientation of the patient, the name, where the patient is, and what is the time. So time, place and person. Next is oral mechanism examination. You examine the labial closure, the lingual range of motion and the facial symmetry by smile and puckering. Then you perform a 3-ounce water swallow challenge. The patient is made to sit upright at 80 to 90 degrees or as higher above 30 degrees that the patient can tolerate. Ask the patient to drink 3 ounce, that is 90 cc's of water from a cup or with a straw in sequential swallows and slow and steady but without stopping. Now assess patient for interrupted drinking and coughing or choking during or immediately after completing a drinking. So if any of the things happen like this, then the patient is having some kind of a dysphagia. So pass is complete and uninterrupted drinking of all the 3 ounces of water without any overt signs of aspiration, that is coughing or choking, either during or immediately after the completion. If the patient passes, then we will see how we will manage this. If the patient fails, then the patient is considered to be a failure for dysphagia and we have to manage the dysphagia. The other screening protocol is the post-extubation dysphagia screening tool. In this, the patient is first evaluated by speech language pathologist whether the patient has any problem or not. If the patient has a problem, then stop, follow speech therapy. If the patient is kept NPO, notify the physician, address the medication and nutritional needs. Next, if the patient passes this, you go to the level of alertness. You check if the patient is alert. If the answer to this is no, then the patient continues to be NPO. If the answer is yes, we go to the next step. We look at the respiratory status of the patient. The patient is able to remain off BiPAP or CPAP for 15 minutes. That is an average time for the patient to take his food. Maintain saturation without support in venturi mask for 15 minutes. Respiratory is less than 30 per minute. If the answer is yes, then you go ahead. If the answer is no, then you stop and reassess. Then you look at the next section, that is symptoms and tube. Patient has any one or more of the following. That patient has a orogastric or nasogastric tube, a history of dysphagia, adverse changes in the lung sound, wet or gurgling vocal quality, history of head neck trauma and other various factors. If the answer is yes to any one of these, then the patient continues to be NPO and we evaluate the patient further. If the answer is no, then we go forward and start administering oral diet. The other is the Bernese ICU dysphagia algorithm. In this, after the extubation or decannulation, you look for the exclusion criteria, that is esophageal injury, NPO status for the patient or terminal extubation. In that cases, we don't give feeding. If it is not, then you look for some characteristics in the patient, like if the patient is ready to attempt swallowing, the patient is awake, upright, can cough, can stick out the tongue, can clean the mouth, is able to breathe freely. If the answer to any one of them is no, then you stop and reassess later. If the answer is yes, then you go for a water swallow test. If the patient passes that water swallow test, then you go ahead with the diet. The other one is the GUS ICU swallowing screening. In this, you do a preliminary investigation where you check the consciousness, presence or absence of stridor, coughing, swallowing of the saliva, drooling of the saliva, change in the voice with swallowing. Based on that, once this is passed, you go to the next level of test, that is direct swallowing test. You first give semi-solids, then liquids, then solids, finally liquids and solids. Then you finally make a whole assessment, what is the protocol. So these are the points. Based on the points, you will decide the diet and whether you will give the diet orally or not. Then there is one more thing that is called the multiple viscosity testing, where you change the viscosity of the fluids and assess whether the patient is able to drink and swallow properly. You start with 5 ml, then 10 ml, then go to 15 ml. So nectar is the middle viscosity. If it becomes more viscous, the feeding that is given, it is pudding viscosity, and if you make it more lighter, then it is liquid viscosity. And you look for coughing, desaturation, change in tone of voice, presence of pharyngeal residue. If any of this is present, then the patient is not good for swallowing. Now that we have screened the patient for swallowing, now what can we do? We found out that one of the problem is there, and I have to now manage the dysphagia. In that case, the first thing that you look for is the diet. Now, the overview of modified diet and postural changes for dysphagia management. The main objective is to implement these modifications to enhance the safety and efficiency of swallowing in these patients. Now, the strategies are designed to compensate for specific impairments in swallowing, ensuring that the patient can consume some amount of food and drink with reducing the risk of aspiration. Now, the components are diet and fluid texture. You tailor the texture according to the patient's ability to swallow. The framework categorizes the food and liquid textures that range from very soft to pureed to regular texture. Now, postural and positioning techniques such as chin tuck, head turn, head tilt can significantly reduce the risk of aspiration during a swallowing. These positions help by altering the geometry of the throat and can prevent food and liquid from entering the airway. Compensatory maneuvers, methods like supraglottic swallowing are taught to patients to help them voluntarily close their airway at the vocal cords during swallowing, enhancing the safety by protecting the airway. Then there are implementation considerations. Active patient engagement is very, very essential. For this reason, you need the patient to be very, very conscious and cooperative. Successful adaptation requires these things. This involves educating and training by speech language pathologists or trained dysphagia therapists. Consistent follow through. Continual practice and adherence to the recommended dietary texture and swallowing technique is crucial. Regular monitoring and adjustment for the patient's progress is also very important. The overarching goal is to allow patients with dysphagia to eat and drink with safety. They maintain their nutrition and hydration through oral route. Now, the next method that is used is the respiratory muscle strength training. You train the respiratory muscles of these patients. So the purpose is specific exercises designed to strengthen the muscles involved in breathing, both inspiratory and expiratory. This type of training is crucial for patients who have been weakened by prolonged illness, mechanical ventilations, and conditions affecting the lungs. What are the benefits? The cough effectiveness improves. The patient is with the improvement in the expiratory muscle power, the patient is able to cough easily and clear the airways. Swallowing outcomes. Improved respiratory muscle function can lead to better control over breathing, swallowing coordination. The ventilator weaning also is helped over here. What are the types of the testing? The most important is the expiratory muscle strength training. It focuses on strengthening the muscles used during exhalation. This can improve breath control, support the stronger cuffs, which are vital for both airway protection and vocalization. The other is inspiratory. It targets the muscle used for inhalation, enhancing overall lung capacity and endurance, which are important for both respiratory health and physical stamina. Now, the training protocol. The specific exercises chosen will depend on the patient's specific respiratory needs and stages of recovery. The factors are adjusted based on patient's current respiratory capabilities and overall health condition. The regime might start with low intensity and few repetitions, gradually increasing the patient's endurance and muscle strength improves. Now, initial sessions may be shorter to accommodate patient's endurance level, but gradually has to be increased based on the tolerance. Patient participation requirement again is a very must. They need to be medically stable to engage in all this, especially those transitioning from ventilator and those who had a recent history of surgery. Understanding and following instructions is crucial, as proper technique is the key to effectiveness of the exercise. The patient's ability to endure longer sessions and more intense workouts will dictate the pace and progress of the training. Adjustments are made based on patient's feedback and physiological signs of fatigue and distress. The main goal of this is to improve respiratory function and quality of life. The facilities not only better improving and swallowing, but also contribute to the greater independence and reduction of the healthcare usage. The next is swallowing exercises and maneuvers. The purpose is to rehabilitate techniques and designed to improve the physiological impairments affected during swallowing. These exercises are aimed at improving both short-term and long-term swallowing functions. The types of exercises: the tongue strengthening exercises, which make the tongue muscle strength and coordination, and the supraglottic swallowing. The maneuver involves voluntary closing the airway at the vocal cord level during swallowing to protect the airway. Tailoring exercises: the selection and customization of the swallowing exercise are based on the detailed findings of instrumental swallowing assessment by the video fluoroscopy or endoscopy. Now, these assessments help in identifying the specific nature of the swallowing impairment. Exercises are tailored to target the patient's unique needs, focusing on specific muscles and functions that require intervention. Participation of the patient again is very, very important. For this, they need some kind of a medical stability. The ability to understand and follow instruction is also very crucial, and they must have good power to endure the exercises that are given. So start with simpler ones, less demanding exercises, and gradually you can progress. The goal is to enhance the safety and efficacy during swallowing. This not only impacts the nutritional intake but also the quality of life of the patient. Now, the session durations, you start with less frequency and gradually increase as per the tolerance. Regular reassessment is vital in these cases. The next is tracheostomy weaning, that is cuff deflation and tracheostomy occlusions. The tracheostomy weaning, also known as laryngeal weaning, involves the process of gradually reducing and eventually stopping the dependence on the tracheostomy tube. The goal is to re-establish the natural airflow through the upper airways, which can improve the critical function such as swallowing, speech, taste, and smell. The interventions that are done are cuff deflation, gradually deflating the cuff of the tracheostomy tube to allow air to pass upwards towards the larynx and the vocal cord, which helps in regaining the normal breathing and speech functions. Occlusion of the artificial airway, this can be achieved through various methods, that is digital occlusion by the fingers, by one-way valves, or by tracheostomy capping. All of this serve the same purpose. Now, the goal of tracheostomy occlusion is to enhance the patient's ability to swallow by restoring the normal air flow and pressure dynamics in the throat, which are crucial for effective swallowing. Improve the sense of smell and taste, which often diminishes with tracheostomy. Facilitate the return of voice and normal speech to allow air to pass over the vocal cords. The patient's involvement again is very, very crucial over here, and the progress is important to be monitored by healthcare professionals. The next is above cuff vocalization. In this, first you do a subglottic suctioning, then you attach the oxygen to the subglottic suction. You occlude the suction port with your thumb, and then you give a 5 liter of oxygen or airflow. Now, it may be necessary to perform oral suctioning as secretion may be blown into the mouth. Now, listen for airway and do not leave the patient unattended during these times. Now, at this time, you must reassess for speech. Now, the point is, anyone can ask you if the patient is able to speak, why at all the patient is on a tracheostomy. Well, this happens in patients who are very, very weak and they are on tracheostomy for the neuromuscular weakness. The voice that we are getting over here is because of the airflow that we are, or the oxygen flow that we are giving through the subglottic suction. That air, when it is going through the vocal cord, is allowing the patient to give some kind of a speech, but the patient is unable to generate that kind of a flow of her own respiratory muscles. That is why we assess the speech, but the patient has not yet got enough power to generate that speech. but limit these trials to 15 minutes. If no airflow, no voice, or stoma is getting any kind of a leak, stop this maneuver. The contraindications are any upper airway obstruction or patency concerns, tracheostomy, which is very new, that is less than 3 days old, a problematic stoma, a continuous subglottic suction is the requirement of the patient, an altered upper airway, or the tracheostomy tube position is not very optimal. Now, these are the methods which help the patient in terms of developing their muscle strength and speech by physical exercises. You can augment these things by electrical stimulus as well. So these are some of the methods where here you are seeing they are giving stimulus to the orbicularis oris and helping in the muscles, and here you can see the pharyngeal muscles are directly getting stimulated over here, which will result in better swallowing of the patient. Now, overall, now we will try to summarize the management of these patients, especially in terms of dysphagia scoring. Now, once the patient is tracheostomized, first screen if the patient is awake, has any respiratory readiness, and the swallowing screening as we have already discussed. If any answer to any of them is no, then stop your screening process for dysphagia and reassess the patient the next day, that is after 24 hours. If you are able to screen all these things, then you see if the patient is able to tolerate cough deflation. If no, then we proceed with endoscopic examination if clinically appropriate. If yes, then we try one-way valve assessment and clinical swallowing evaluation. If there is no dysphagia, then we start advanced diet. But if there are concerns, then we go for instrumental assessment by endoscopy. Finally, you can go to any of the plans that we have already discussed, the compensatory techniques or the targeted rehabilitation protocols for improving the patient's dysphagia problem. And then you reassess every day and see if my interventions are showing any signs of improvement. Now, this was for tracheostomy. For extubate patients, similar protocol. First, you screen the consciousness, respiratory readiness, and swallowing screening. If it is a no, you reassess after some time. If it is yes, then you do your testing. If there is no dysphagia, start your diet. If the screening has failed, do a clinical swallowing evaluation. Then if that also shows concerns for dysphagia, then go for instrumental assessment. And finally, once the dysphagia is diagnosed, you go for your plans as per the compensatory techniques and the rehabilitation protocol. Thank you for your patience.